Your ICU patient's SATs are dropping. You've adjusted the ventilator and increased the oxygen, but the numbers continue to slide. Right now, the physiology is failing, and standard interventions aren't working because they aren't targeting the actual breakdown. We usually rely on pH, PCO2, and PO2. These serve as a basic alarm system. They report that an emergency is happening, but they offer no insight into the structural cause. To regain control, you have to extract the hidden parameters. The standard blood gas data contains the math needed to pinpoint exactly where the physiology is collapsing. Look at this standard printout. You see your basic reactive values. Looking past those numbers reveals two specific diagnostic pillars: oxygenation metrics and metabolic metrics. These hidden parameters provide a direct path toward identifying and targeting the underlying physiological culprit. The first place oxygen transfer fails is at the microscopic bridge between the lung and the blood. This diagram shows the specific anatomy. On the left is the alveolus, your air sac, and on the right is the capillary. The A-a DO2 gradient measures the efficiency here. It calculates the mathematical difference between the oxygen sitting in the alveolus and the oxygen that actually crosses into the arterial blood. This graphic illustrates that gap. Big A for alveolar oxygen minus little a for arterial oxygen calculates exactly how much gas is lost across that barrier. A normal baseline value in neonates is 10 to 20 millimeters of mercury. Any climbing number sets a strict reference point for impending pathology. By isolating this specific gradient, you remove the cardiovascular system from the diagnostic equation entirely. You prove exactly how well the lungs alone are functioning. Once that A-a DO2 value starts climbing out of the normal range, it triggers a branching diagnostic tree. This chart maps out the deficit. If the gradient is normal or mildly elevated, oxygen transfer is intact. You have a pure ventilation problem. Air simply isn't moving. If the gradient is moderately elevated, between 30 and 100, you have a VQ mismatch. This points to localized lung damage, like pneumonia. Severe gradients, over 100, require you to move clinical suspicion away from simple lung mechanics. You are facing a shunt, or a severe diffusion defect. Knowing the exact A-a DO2 number instantly maps the team away from guesswork and forces you down one of three distinct pathophysiological routes. If lung mechanics are sound but oxygenation is failing, we must look for cardiovascular detours entirely bypassing the lung. Imagine a high-pressure stream violently bypassing its filtration matrix and dumping directly back into the main line unprocessed. Fraction shunt is the exact percentage of blood that fails to pick up oxygen because it structurally detours around the pulmonary system. Here you see the anatomical reality. Venous blood aptly bypasses the alveolus, polluting the arterial supply. A normal F-shunt sits under 5%. As that number climbs, it reveals escalating pulmonary resistance or structural cardiac issues. This warning scale defines the clinical danger zones. Push past a 20 to 30% shunt fraction, and the risk of mortality spikes.
For neonates, there is a specific rule. A high shunt equals persistent pulmonary hypertension, PPHN, until proven otherwise. A climbing F-shunt indicates that a localized respiratory failure has escalated into a structural cardiovascular emergency. To prove which diagnosis you have at the bedside, you administer 100% oxygen and observe the physiological response. This table breaks down the response. If the problem is localized lung damage, the patient's oxygenation improves. A lack of response to pure oxygen proves you have a structural right-to-left shunt. Oxygen fails to correct a shunt because the gas physically cannot reach the detouring blood. We lock in the final severity using this mathematical ratio, the respiratory index, or RI. The RI calculates the size of the oxygen transfer problem relative to the actual usable arterial oxygen left in the patient's system. Together, the A-a gradient, the X-shunt, and the RI provide a complete map of any oxygenation failure. Now we execute a hard shift. We know what the lungs and heart are doing, but we must measure the entire body's chemical resilience. The body protects itself from acid using finite chemical buffers, and under stress, those protective elements face rapid exhaustion. A patient's true systemic stability relies entirely on this invisible buffering capacity holding the line. This diagram illustrates total CO2, or TCO2. Bicarbonate makes up roughly 90. A chemically stable patient sits securely in the neutral green zone. Mathematically, SBE measures the precise amount of base required to neutralize the blood and return the pH to normal. But dropping past -10 crosses the critical deficit threshold. It indicates imminent systemic collapse. A severe negative SBE demands immediate aggressive intervention, fluids or chemical buffers. You cannot fix this with a ventilator dial. Oxygenation parameters measure the lungs, but SBE quantifies exactly how much chemical runway the patient has left before total systemic failure. We have to abandon the dangerous habit of reacting only to a dropping PaO2 alarm. Instead, use this mental model. Ask these 3 specific questions every time an ABG worsens. Follow the gradient rule to isolate the lungs and the shunt rule to diagnose true anatomical bypassing. This suite of hidden parameters provides the mathematical context needed to navigate an ICU crisis. If you found this clinical breakdown valuable, hit the like button and subscribe to the channel for more high-level medical and technical deep dives. Applying these calculations brings the patient's internal physiology into focus, allowing for a targeted clinical response at the bedside.